Hi, my name is Karen Cantor, and I am answering case 3 and 4 of the Unit 2 case studies assignment. In case 3, the patient's serum insulin levels before and after the glucose loading test are well below the control values. His insulin levels are low, so we can assume his fasted blood glucose levels are above normal range. This 5-year-old boy most likely has type 1 diabetes. The patient has persistent thirst or polydipsia and frequent urination, also known as polyuria, which are common symptoms of hyperglycemia in patients with diabetes. Regulatory enzymes that are active in this patient's condition are enzymes used in the metabolic pathway of gluconeogenesis. Pyruvate is converted to oxaloacetate and then to phosphoenol pyruvate by enzymes pyruvate carboxylase and phosphoenol pyruvate carboxykinase. Transcription for the gene for phosphoenol pyruvate carboxykinase is increased by glucagon and cortisol. Insulin inhibits the expression of the gene for PEPCK. Therefore, low insulin would allow for PEPCK to be active. Decreased insulin levels allow for gluconeogenic precursors like amino acids to be broken down from muscle protein. Insulin typically inhibits gluconeogenesis, but because insulin is low, the hormone glucagon stimulates gluconeogenesis. Fructose 1,6-bisphosphatase is also an enzyme that is activated in favor of gluconeogenesis. For case 4, this previously healthy 2-month-old female baby most likely has glycogen storage disease, the inability to utilize glycogen. The patient's symptoms include hypoglycemia in the early stages of fast, increased lactate, and an enlarged liver. Liver glycogen is important for maintaining blood glucose levels during stages of fast, but the baby is still hypoglycemic between feedings. This immediately makes me think that the patient has the inability to break down glycogen to glucose. Epinephrine is a hormone that signals the need for blood glucose. It increases cyclic adenosine monophosphate and stimulates hepatic phosphorylase kinase, initiating the breakdown of glycogen to glucose. However, even after epinephrine is given to the baby, she remains hypoglycemic. Lactate in her blood is elevated because now her liver must oxidize lactate to pyruvate, which is then used to create glucose by gluconeogenesis. If we consider hereditary fructose intolerance and galactosemia as her diagnosis, the patient would need to have her fructose and galactose levels tested, which is information we don't have. Liver failure, hypoglycemia, and lactic acidosis may be symptoms of hereditary fructose intolerance or galactosemia, but the patient would also have nausea, vomiting, signs of GI upset, and failure to thrive. She does not have symptoms of glucose-6-phosphate dehydrogenase deficiency because G6PD deficiency affects red blood cells, and a notable symptom would be jaundice due to hemolytic anemia.